So which referrals get tested? So as we've talked about a little bit, the recurrent miscarriages. So these are the R318 test code. These are defined as 3 or more miscarriages. When the test directory was first issued, this meant that they had to be consecutive miscarriages, but this is no longer the case. It's just a total of 3 miscarriages at any point in their lives. This R code has essentially been used to replace a lot of parental karyotypes. So for those of you that remember life before the test directory, we used to karyotype a lot of couples who'd had recurrent miscarriages to look for chromosome abnormalities or balanced rearrangements within the parents. This is considered not such the efficient way to do it, and we should be looking at the pregnancy losses themselves. And this has been defined, recurrent miscarriage has been defined by the Royal College of Obstetrics and Gynae, I think, and within our test directory is 3 or more miscarriages. The other test code that can be used is an R22, so this is a fetus with a likely chromosomal abnormality. So this can be due to a fetal loss or termination or miscarriage with fetal anomalies, and this can be any gestation. If you have fetal anomalies, we can receive it from any gestation, or it is considered to be the death or a stillbirth with no anomalies from 24 weeks in the absence of other likely causes. So by that we mean if the cord is around the neck, that is considered to be the likely cause of the stillbirth or the death, so that would not be eligible for testing. Things which are not eligible for testing are spontaneous premature rupture of membranes and hydromnios. These are not included in the testing. Spina bifida and neural tube defects. Now these haven't actually been included for many years, but I think they've crept back into our testing within the laboratory. So we've recently become a little bit more strict on that. So if they've got spina bifida or a neural tube defect, but the absence of any other anomaly, they are not tested. There's no genetic association with spina bifida and neural tube defects. So the other things which have changed fairly recently are that the confirmation of a prenatal testing result is not required. So we no longer need a sample once a termination has occurred or a pregnancy loss has happened following prenatal testing, and private testing is not available anymore. So which referrals get tested? I've had a few questions about what is tested and what's not tested recently, and as I say, there have been a few changes within our lab and within the test directory. So we had questions about losses between 12 and 28 week losses without a post-mortem and no obvious anomalies. Samples from 24 weeks can be tested. So this was changed in the last test directory. It used to be classed as 3rd trimester, and this was a little bit tricky because different labs and also the Royal College guidelines term 3rd trimester slightly differently. So the test directory has been more specific and now says that samples from 24 weeks can be tested with no fetal anomalies. So we will now accept those. So for those of you that may not have been sending samples between 24 and 28 weeks, this can now be done, but that is, as I said, that was a change with the last test directory. Between 12 and 23 plus 6, if there's no anomalies and no history or recurrent miscarriage, then these ones aren't eligible for testing. So that's quite an important caveat. And I know this is a bit of a struggle for midwives and consultants in general, that it's hard to decide with some of these losses whether there's anomalies or not. So the question of should you offer genetics just outright for all samples is probably not. We need to be mindful about what we're offering. A sample can be sent to the lab and we will extract DNA, as we know that the repeat sample is not possible. However, testing may not be activated. If they're not getting a post-mortem, this is a bit more tricky. They're very unlikely to ever be offered testing. So, as I say, for these patients, I'm not being very clear, but for these patients, where there's no fetal anomalies between 12 and 24 weeks essentially, and they're not having a post-mortem, it's very unlikely that these patients will ever be activated for testing. So I think these are the difficult cohort to really counsel for you on the front line. If there's no obviously anomalies, but it is going for a post-mortem, then we are more likely to get a test request because they may find something on post-mortem. So I think it's tricky. I think you have to offer genetics if you feel it's useful and is going to be activated. If you're aware of these guidelines and the test directory and you feel like it's not ever going to be tested, then it may not be so useful to send the sample, but we appreciate that that's quite hard to judge and hard to counsel the patient for. So the testing's changed, and why has it changed? Well, it might feel like the testing has been reduced, and I suppose this is partly true, but we simply cannot test every pregnancy loss. We don't have the resources, and unfortunately miscarriage is a common finding in pregnancies, so we simply can't test every single sample. As I mentioned before, we used to test parental karyotypes, but testing the pregnancy losses is considered more appropriate, but then it's deciding which pregnancy losses are tested and which ones are more likely to potentially to show a genetic reason for the pregnancy loss. So the reason we don't test pregnancies with no anomalies between 12 and 24 weeks is that there's been shown to be a very minimal pickup rate in genetic anomalies. We do understand that any testing offered is useful in terms of dealing with grief and mental health, but it will only provide in some cases a reason for why that pregnancy loss, which as I appreciate is useful for that patient, but sometimes it's also not useful if the result is normal. So the testing is primarily aimed at, and this is why it's been sort of reduced into these two categories, is recurrent miscarriages to looking for an abnormality which may indicate a parental rearrangement, and then the later losses we're looking for more subtle genetic abnormalities, but more it's probably about reassurance for future pregnancies.